Yo! So, my name is Seabass. I'm a PGY4 first year kidney fellow, and I am stoked to be here today to talk to you about chronic kidney disease in primary care. One of the things that I've been blown away by this year as a first year kidney fellow is how unnecessarily complicated we as doctors can make kidney care be for our patients. I'll give you a perfect example. In the fall of this year, during one of my initial chronic kidney disease visits with a patient, I realized 20 minutes into the visit that she had no idea what organ system she had come to the doctor for. Now, granted, part of this was my naivete as a trainee. I made a mistake. I didn't ask her some open-ended questions up front. But part of her misunderstanding is baked into the way that we as doctors talk about kidney disease. For example, take a look at the superfluous synonym that is renal. This patient had been told to come to a renal doctor, and that certainly contributed to her misunderstanding. I think that as physicians, one of the best things we can do is break things down for our patients in an accessible way, because only in doing so can our patients take ownership over their care and feel like they're engaged in a collaborative relationship with their physicians to work on being healthy. With that in mind, let's take a peek at the patient's perspective and tackle the top 3 questions that I get in kidney clinic.
Kidney Best. Kidney Best Talk.
All right, so question number 1 is, Doc, why am I here? I've interpreted this question to mean, what is chronic kidney disease? They're sort of 2 sides of the same coin. So what I like to do is a 2-pronged approach with patients. The first is I tell them a little bit about the functions of the kidney, and then I make sure to label for them a few key adjectives that I want them to take away from our initial visit. In terms of explaining the functions of the kidneys, I keep things basic so long as the patient who's presenting to me isn't having really advanced chronic kidney disease on the order of, say, stage 4 or 5, where they've started to already become symptomatic. If they're asymptomatic, then I keep things simple. I tell them your kidneys clean toxins in your blood, and your kidneys remove fluid that's excess from your body. So, clean toxins, remove excess fluid, simple. The second thing I like to do is make sure that I've established a few key adjectives for those patients. The first we've already alluded to, which is that if the patient is stage 3A, 3B, or even for some patients who are stage 4, they're likely asymptomatic from their chronic kidney disease. And so I let patients know up front, look, this is a disease that is silent, much like your high blood pressure, or if they have it, type 2 diabetes. Then I pivot to another adjective, which is to let them know that kidney disease is permanent. So if I'm labeling them with CKD, by definition, I'm telling them that this is something that they're going to be dealing with for the rest of their lives. Sometimes it can help to use a counterexample. So I might tell them, for instance, if you've ever had the flu or you've had pneumonia, then those are things that either tincture of time could make better, or perhaps if your doctor thought it was appropriate, you may have been given some antibiotics. CKD or chronic kidney disease is not like that. It's something that you're going to have for the rest of your life. And this is my in and my window to tell the patient that we're going to develop a long-term relationship and how I want to see them on a regular basis, much akin to their primary care doctor or their dentist. The last adjective that I like to use for patients is to let them know that CKD is progressive. And so I have to be careful about how I say this because I certainly don't want to scare them and let them know that their disease is going to quickly get worse. But at the same time, I want to let them know that if we don't do anything, that in all likelihood, their disease is going to either slowly or perhaps more quickly get worse. This idea of chronic kidney disease being progressive, if we look at things as glass half full, can be empowering for patients because then I immediately will segue, and often it's a natural question from the patient later on in the visit about what is it that they can do to prevent that progression. All right, so to recap those three adjectives, we let them know that it's silent, we let them know that it's permanent, and we let them know that it's progressive. The second question that is commonly asked during an initial chronic kidney disease visit is, Doc, will I need dialysis? First thing, as the child of two therapists, I would be remiss to not tell you to make sure that you acknowledge the emotion behind that specific question. If a patient knows anything about dialysis, then the idea that they themselves may need that therapy can be incredibly scary for them. Make sure you label the emotion and then turn it back over to them with an open-ended question to elicit a little bit more from them before you move on. Next, I then tell the patient, well, in order to answer your question as to if and when you might need dialysis, that we are going to together have to routinely monitor 2 labs. And as a millennial, even though I might not share this with the patient, I'm always thinking in my head when I bring these 2 labs to mind of Cardi B's smash hit, Bodak Yellow. Why Bodak Yellow specifically? Well, when Cardi B labeled her song Bodak Yellow, she didn't call it Kodak Yellow because she was alluding to the blood gang. Bodak for Bloods. She makes bloody moves, she wears bloody shoes, and as the kidney doctor, I know that I need a blood test, specifically the serum creatinine, in order to be able to stage and prognosticate chronic kidney disease for my patient. That's the easy part, you say. Well, sure, because the serum creatinine is baked into the basic metabolic panel, and people don't tend to forget that if they're monitoring kidney function, they need to get a serum creatinine. But here's the thing. We want to remember Cardi B's Bodak Yellow for that second word in the title, which is yellow. Yellow is a prompt that calls to mind urine, and it reminds me that I need a urine albumin to creatinine ratio in order to make sure I have that second part of the 2 laboratory values to be able to stage and prognosticate. Once you have those 2 values, then you need to get a general sense of the type of patient that you're dealing with because you have 2 options to answer their question about prognostication. You can take the qualitative approach, which would be the KDIGO heat map. You can easily pull up that picture in clinic on your desktop and show it to them to give them a sense of where exactly on the heat map they are. If, however, the patient is the type of person who would prefer more granular data, then you can use the kidneyfailurerisk.com equation. Simply call up kidneyfailurerisk.com either on your phone, your smartphone, or again on your desktop in the room with them. Punch in the appropriate 4 parameters and you get a beautiful infographic with some nice text that you can share with the patient. So the last common question that we get during an initial kidney visit is, Doc, what about my diet? What can I do to help my kidneys with what I'm eating? The short answer for me is typically a global question of triaging. There's so much to cover in an initial visit with a patient, and I know that I'm going to be making behavioral recommendations to them about things that I want them to do to better their health that are, in my mind, less complicated than dietary augmentation, that I don't want to spend a large chunk of my initial appointment with my patient getting into diet recommendations. And that's not to say that nutrition isn't incredibly important for chronic kidney disease. It's just that I don't tend to prioritize it on my first visit. What I do, however, is a twofold approach, if you will. The first is that I use it as an opportunity to introduce the notion of multidisciplinary care to the patient, and I ask them if they'd like me to refer them to a dietitian who is going to be much more qualified than I am to get into the nitty-gritty with them about specifics that they can do to change up their diet. And the second thing that I like to do is I use it as an opportunity to introduce certain concepts to them, like lowering sodium, being aware of sodium altogether, that is to say, starting to look at packaging and labels, since most of sodium ends up being built into prepackaged foods, and the idea of a low potassium and a low phosphorus diet. And that is a perfect segue for me to direct them to my favorite patient-centered website, which is kidney.org. With a couple quick clicks, they can easily pull up some kidney-centered dietary tips on kidney.org, and I like to make sure that they understand that this should be their hub for all kidney-related questions when they're navigating the internet. All right, so let's recap. We talked about the top 3 questions in Kidney Clinic for an initial chronic kidney disease visit. Why am I here is usually getting at what is chronic kidney disease. We like to let the patient know some basic functions of the kidney and also to let them know that their disease is silent, it is permanent, and for most patients, progressive. The second question is, do I need dialysis? Which inevitably gets to this idea of staging and prognosticating for kidney disease, remembering that you're going to need both serum creatinine and a urine albumin to creatinine ratio in order to accurately answer this question is key. Last but not least, if patients have questions about diet surrounding their kidney care, I like to direct them to kidney.org and get them plugged into that website as early as possible. That's it.